Well, hello. Good morning or afternoon, depending on where you are in the country, apparently. My name is Matt Teichner, and I'm a senior project manager for Sharp Healthcare. My usual day job is building hospitals, but occasionally I get to build things that are a little bit different than hospitals. And we thought it would be interesting to talk to you today about one of the things that Sharp does that I think a lot of people don't know a lot about or see a lot of. And that is our hospice program, and specifically our hospice homes. With that, I'd like to introduce you to Susie Johnson, Vice President of Sharp Hospice Care.
Thank you, Matt. It's a really an exciting time to be able to share our story with you and how we have integrated hospice into the community setting for people who are really, really ill. So go ahead, Matt.
Sure. We always like to start a meeting off at Sharp with a reflection. And in talking about hospice, I always think about sort of time and time on our hands. And we must use time wisely and forever realize that the time is always ripe to do right. From Nelson Mandela, and you can see next to this is the dedication to the third hospice home we built in Bonita, which was a big part of my life for a long time and still is. So with that, I'd like to let Susie tell us a little bit about Sharp's hospice program so we can kind of understand the context of these homes and why we built them.
Thanks, Matt. So in the U.S., more than 95% of all hospice services are provided in a patient's own home or the place that they call home. So it could be skilled nursing facility, assisted living, or a person's own home. Very little of hospice care is actually provided in an inpatient care setting. That said, most people want to die in their own home, yet less than 40% of all deaths in the United States do occur in a person's own home. So we were interested in figuring out how we could solve a problem and reduce a gap in where people want to die and where they actually do die. So given that there are very few options for dying people who need a higher level of care other than an institutional care setting such as a hospital, we began to imagine maybe homes in community settings. And also because healthcare is local, we really thought, we should be able to brand this kind of service to Sharp Healthcare, which is the largest health system in San Diego County. So from there, Sharp Hospice became a Medicare certified hospice program in 1992. We're currently the largest hospice program in San Diego. Our average daily census runs right around 450 patients. Plus, we have about 205 patients that are on our home-based palliative program, which is a natural feeder into our hospice program at some point. In late 1996, Sharp Hospice was gifted with a home in a residential community near one of our hospitals. A decision was made that we should imagine that home becoming a hospice care center. So we began a partnership with our foundation, Grossmont Hospital Foundation, to create a philanthropic model that would allow for us to have this home turn into a hospice facility. So in 2001, Lakeview Home was opened. Now, Lakeview Home started out as a rather small home in a residential area. We remodeled it, created some extra living space, 4 private bedrooms, beautiful backyard overlooking a man-made lake, and hired nurses and physicians and social workers and so on. So here's a picture of Lakeview Home, and it has served about 5,000 patients in the last 20 years, just at that home.
And it really is this is where we started, and it's a true house in a residential neighborhood. But even with sort of its size and quaintness, we'll say it's beautifully sited over that lake behind it, which you can see a little bit beyond the patio there, and provides a wonderful respite for people.
Yeah, and that was what we're really trying to do, is create a home-like environment, but with all the accompaniments of a healthcare facility, which we were able to do. So with the success of Lakeview Home, and really the community embraced the model very, very well, we then began the journey to fundraise and create our next home, which is called Parkview Home, and that opened in 2009. And then in 2014, we really accelerated our model of care, which Matt's going to talk about, and opened Bonita View Home in 2014. And we're going to open Mountain View sometime in early 2023. Matt?
Yeah, I'll get into the home in just a minute. I think before we go there, we just wanted to cover a few of the parameters that these homes essentially need to meet. When we started out with the first house in Lakeview, these were considered congregate living facilities, and it has sort of morphed in time into an actual hospice license category. But note, the goal, I think, was a balance between really trying to create just a home that someone could be in if they were unable to be in their own home. But the fact that once we do that and we are providing licensed care, it has to be a little bit more than a home.
Right. So while the home looks like a home, it actually meets the requirements of the hospice conditions of participation for general inpatient level of care, including staffing, dietary, other things like that, and the CMS Life Safety Code, which we'll get into a little bit more discussion as we get further in the presentation. So the home has this residential feel, but people who do come to the home are very ill. They're either there for symptom management or imminently dying. Now, patients stay on average about 5 days. And what we have had people stay as little as 1, and we have people stay as long as over a year. So there's really a wide range of the length of stay. Our neighbors' concerns, I think at first, with our very first home, our neighbors were very concerned about parking. And I think they had an idea that they weren't sure how we would organize mortuaries coming to pick up people who had passed away. So those were really the two biggest concerns. Fortunately, we've been able to mitigate both of those concerns very well, and now we're just really seamless in the community, and we're like any other busy household. Why we only have 4 to 6 private rooms? Primarily because of the residential coding requirements, which Matt will talk about in a minute. And you know, the smaller facilities really give way to continuing to have that residential feel versus an institutional feel. So that's why we've kept the homes at 4 to 6 private rooms.
And as Susie was saying, when we started out with Lakeview, we had a house donated to us, and we essentially did some minor to major remodels on Lakeview and Parkview in order to make them work for the hospice use that they needed to accomplish. What happened with Bonita View, our third house, is we actually found a site and decided to start from scratch and build an actual home exactly suited to the task at hand. And I think in doing so, we created something new, a new animal, I'd say, in the healthcare realm. And when you see the house, when you go inside and experience it, I think you feel that. The goal, again, was to have that residential home feel like you're there, but also to have a building, like if I'm building a hospital, that serves its need exactly, without a bunch of workarounds or other, inability to do your job efficiently. And I think Bonita View succeeded very well in taking those two sometimes conflicting goals and finding a meet in the middle point that worked for our operations and for the community that we were serving. So in doing so, we really did exceed the quality of the previous two facilities, as it's a new building and everything in it is properly sized and located to work right for the program. Bonita really started, or even kept on the lines that we're going to look at in the new facility we're planning, is what neighborhood are we in? We want to reflect the character of that neighborhood, not necessarily make a sharp building that sticks out and says, here you are at, Sharp Healthcare, but something that looks like it belongs, feels right in the neighborhood, is a good neighbor like any of the other neighbors in your neighborhood. So this house, as we were saying, accommodates 6 patients, which was a jump for us. The previous 2 houses had been 4 patients. And one of the main reasons to jump to the 6 is as you serve more patients, you're certainly, as a facility, able to deliver more just healthcare to the community. But there is a limit. Once you hit 7 patients, the building code does completely change on you. No longer are you sometimes even allowed to build these facilities in a residential neighborhoods, and where you are allowed in the neighborhoods, you're going to have to build it more in line like a skilled nursing facility with rated corridors. You can't do type 5B construction. You're jumping into 5A or even a higher construction type. So the cost of building the facilities and the ability to do so go up dramatically. This facility, I don't think of it just as the inside of the house. It's really how we handled the whole site. So you've got your 6 patient rooms, but each room is attached to an outdoor area as well, with a private patio for the family's use, attaching to the bigger public outdoor spaces. As we get into the house, it's important that this is not just a home for the 6 patients that are in it. It's a home for the families and extended families of the people who they're saying, who are saying goodbye to their loved ones here. This is the last place that they'll talk or see each other in most instances when they come here. And we wanted space for those people. We wanted them to feel welcome, to be comfortable, to have elements of privacy and community at the same time. So you see a lot of spaces like a living room that would be in your home, but it's built to accommodate many more people. And especially at our site in Bonita, where really, when a loved one is passing or even sick in the hospital, we don't typically see, 2 or 3 relatives visiting. We see the whole family. And that's pretty consistent across the board. So with 6 rooms, you could be accommodating 16 family members times 6, maybe not always all at the same time. But I've been to this home, one day for me, that was a tougher day. I was just there for a yearly inspection. And the director of our skilled nursing facility over at the hospital at Chula Vista actually was in this home and had passed. And there were hundreds of people there saying goodbye to her on that day. So this house really does have to be able to accommodate a crowd and do it in a dignified, safe fashion. As we keep moving through the house, one of the elements of this house that becomes complicated, but we're trying to make a good feel for the visitors as well, is the kitchen and the cooking facilities. You're putting kitchens in these houses, and you want the kitchen to look and feel like a residential kitchen, but the purpose of it has to primarily be patient meals. And when you're making meals for patients, there's a lot of agencies involved, the county health department and the Department of Public Health for serving patient meals. So the kitchen has to sort of pass muster from a commercial, semi-commercial level when you're doing that. And that does mean that while we'd like the family to be able to come in and stick things in the refrigerator or heat up a sandwich or make themselves a meal, they're really not allowed to be in there because of the commercial patient meal element that has to be fulfilled as well. So to try and mitigate that, in the other homes where they're basically not allowed, we created in Bonita View a kitchen, a main kitchen that's duty was creating patient meals, but then a family kitchen and sort of dining area around it. So, in the family kitchen, they have a refrigerator that the families can use. They have a microwave. They have storage and utensils and a sink for doing dishes and things. I can't provide them an oven for cooking and stuff like that. That's a a little bit dangerous. And in a residential zone, you're not allowed to have more than one true kitchen, which is always defined by cooking. So what you're seeing here is the family kitchen area and dining area. And, we're creating some different seating accommodations because, again, we may have multiple families and people in here using the space. As we move through the home, there's other spaces that are, again, designed to create more private areas of reflection for different tasks that need to be accomplished. We have a meditation room that is chapel-like, but it's not explicitly a chapel. I always tell Susie it reminds me of like the last episode of Lost where he's back with his father and like every religious symbol is sitting on the table. I kind of see elements of that in here. I think our designer did a wonderful job making this room open and closable. There's a big wood barn door that can shut it off, but when it's open, even provides a nice focal element in the room. From the room, you can look out onto the patio and see, our feature tree and citrus trees and smell all of the wonderful smells of the citrus growing in the yard. There's a consult room that is sort of a backup meditation room. It's designed a little bit more so someone could have a meeting with a physician or, a sit down and discuss their loved one's conditions or just get away. And it has pocket doors, so it can be open to the living room for other spaces, or it can be closed off for a private conversation. As we get into the outdoor spaces, you can see this was designed as sort of a half hacienda. So the rooms make a big L, creating this courtyard that's on the periphery is sort of the private patios that are for each individual room, with the more public patio coming down and circulating itself around a big feature tree, which was a magnolia that we planted. It doesn't look very happy in this picture, and unfortunately the first magnolia, we did have some irrigation issues and it didn't make it, and it was replaced a year later. So we had some misfortune as well, and that was a pretty big expensive tree too, so it was a tough one to have happen. But if that's the worst thing that happens on a construction job, you're doing pretty well. So aside from the house, a big note, and one thing I think we're all very proud of, is that this home was built with 100% donated money. It was funded by Philanthropy. I don't know, Susie, if you want to talk a little bit about the campaign that was generated and that led to us being able to do this.
Yeah, thanks, Matt. So Philanthropy is a really big part of the hospice home story. And as the Lakeview home became that first anchor for us through a philanthropic gift, it really provided the energy for us to continue to fund the hospice homes through philanthropic efforts. What we've learned is that people want to be part of something very significant and very meaningful. So we, for the Bonita View home, we had a capital campaign of about $4 million, as I recall. Oh, it says $2 million there. I think it was a little bit more, but we were very easily able to get key contributors involved, and it ranged from personal gifts all the way to our contractors who helped support the drive. The donations directly received from hospice staff, Sharp Healthcare employees, corporations, businesses, small, big, medium size, and of course our contractors helped us as well. So for the next home, we're doing exactly the same model. Really, we're going to have a very large campaign. I think over a $5 million campaign this next time. The celebration that people feel when they've accomplished something so significant is very heartwarming. And beyond that, we have made so many friends of hospice now whose family members have actually used the home. So part of this is goodwill building as well. So thank you.
So part of the note, and I touched on it earlier, is getting this home built was complicated. There were multiple permitting processes, and it's a non-OSHPD job for those on the line who know of OSHPD and California hospitals, but it is a licensed facility by CDPH, or the California Department of Public Health. in a way, you're almost better off having OSHPD on your job if that's your goal, because they are looking for and inspecting for the things that the CDPH needs to see in order to license you. The county building department for San Diego is not necessarily looking for those things. They are just making sure you comply with the zoning code and the building codes connected to building a residence. Our site actually had a bit of a 100-year floodplain on it, as we're right next to the Sweetwater River. And so we had to go through LAFCO, which was a federal government agency, to get permission for our plans and it was just like a teeny tiny little corner of the site where the floodplain crossed it, but that was enough. And so that complicated our permit process through the county. But as I said, afterwards, you need your fire marshal to sign off so you can bring in the California Department of Public Health to license you. And the big thing is they want to see permits for every little thing you've done around the property that normally wouldn't even require a building permit through the county. So that did require some partnering with the county agencies in order to get them to actually permit things that they didn't really want to bother permitting. So it's an interesting process to coordinate all of those agencies. But as I've found, you do have to make the agencies your partners in order to make these things happen. And often people see the building department as a bureaucracy and not as a bunch of people who you need to reach out to be your team members and partners. And in doing so is really what was able to finally kind of get this out of the gridlock of the permitting system and to finally make it really happen. And even the county supervisor who owns this area, I think in the end, donated money to this project. So, I mean, it was certainly well embraced by the people once they knew what we were trying to do. And Bonita's definitely a community that cares about the character of their neighborhood. So we had many, many meetings with neighbors, and I actually went door to door, ringing doorbells to every one of them to talk about the project, to talk about some of the things we were doing to improve their neighborhood as part of it, to really build goodwill for what we were doing and not make them feel like Sharp's coming here and planting a facility next to you, live with it. That's not at all the message that we wanted to send. Some of the things that came up, there's actually a horse trail that ran right along the side of the property. And weirdly enough, that was a thing that the county completely missed in all of their plan checks. And we thought there might be, but we couldn't confirm it. And everyone there said, well, it's not on any of our maps. So the day I put up my construction fences, I had angry horse people all of a sudden. And I'd never seen a horse there before that, which was the weirdest thing. That was the day that the horses showed up, that the fences went up. They're like, you're blocking our horse trail. So at that point, we got to the bottom of where it was and where it was going. And it was actually kind of a terrible trail, to tell you the truth. The horses were walking in like the culvert ditch next to the road. And, without too much terrible effort, it was a little bit of redesign civil wise. We actually gave 10 feet of our property to make that horse trail much nicer and wander through the pepper trees along the side of the property. And instead of putting a wood fence, I put up the metal fence you see, because we felt the families and the people in the house it'd be nice for them to see people walking by on horses. So in the end, I think it became a nice feature of the site. Another thing we did is a quarter mile of the street was repaved, and this was a bit of a battle, but I think a nice concession in the end. We were actually adding a sewer line in the street because there was no sewer to this area, and the sewer line was going to serve all the neighbors. We gave everyone a lateral on it, but when it was all done and you could kind of see the patching, like the road was smooth, but it didn't look like a new road. So, in the end, we just repaved the whole road and made a new road for everyone on the street. So really an upgrade and a benefit to the neighborhood, because no one had sewer before. Now they've all got a lateral. If they want to, switch to the system, they can. A big deal was keeping the neighbors informed. And as I said, when I was going door to door, knocking on doors, one of the things I was talking to them about is the lateral, because in order to give someone a sewer lateral, I need to trench up to or through their yard. And I didn't want our contractor doing something to their yard that they didn't know about and want to have happen, break a fence, anything like that. You got to think life is realities, and doing work can cause side effects, and you want them to know what you're doing and why. And I gave them the choice. If they didn't want the lateral or they didn't want it to come too close, we didn't do it because we didn't want to risk hurting something that was important to them. So on that, we had community events in the community centers, and everyone who lived nearby was invited to the grand opening. This wasn't like an event that we were excluding our neighbors from. We're going to be part of their neighborhood. We wanted to invite them into the home to see what was going on there, to know really everything we could think of to make them a part of the project. And just a note, a few of them actually inquired about volunteering in the house once it was open. Like they were actually excited that it was there and wanted to be a part of what we were doing. Mm-hmm. So flashing forward from when we completed construction in late 2014, just before Christmas, we had our grand opening in January after the holidays, and then we awaited for CDPH to come license the house so we could see patients. And that's where we ran into a bit of a problem. And I don't know if Susie, you want to chime in any here, but that's when the licensing process changed, actually.
Yeah, so the licensing process changed in the state of California and for allowing for hospice facility licensure. And so CDPH had not had experience with that. And next time going forward, we'll engage CDPH right up front. I think that was one of the lessons learned. If we had done that at the very beginning, we probably would not have, they probably would have responded faster and we wouldn't have had some of the issues that we had. But we eventually did get it done, and we were able to open about a year after the home was completed. So next time we won't have that problem.
No, and I literally, like, it used to be licensed as a congregate living facility. They created a new license category, and they really actually weren't prepared to license any hospice house at that time. They were getting the process together. So it was just an unfortunate set of timing circumstances, but that process is there now, and it's laid out clearly, I think, for us on the next one and for anyone who's trying to build a hospice house.
Yeah, and to that point, for example, some of the California rules are rather archaic too. So we had a Pyxis, an automated pharmacy medication dispensing machine, and we learned through the CDPH visit that in the state of California, skilled nursing facilities, which is the closest licensure to the hospice home, cannot have automated medication dispensing equipment. So that's an example of where we ran into a hiccup or two.
Yeah, for me, some of the hiccups are on this list. And I think this is a good slide for anyone planning to do a hospice house, because as Susie is alluding to, really now that they have this hospice category, most of the inspectors for CDPH are looking at it like a skilled nursing facility. And that comes down to the fact that CDPH goes by NFPA 101. And NFPA 101 doesn't have categories for SNF or for anything else. They've got healthcare occupancies, business occupancies, existing ones and new ones. So if you build this after, basically it was anything after January 1st, 2015, more or less, it was a new facility, because that's when they adopted the 2012. And if you were earlier than that, you were an existing facility by the definition. But either way, they're basically looking at the same things they'd be looking for in a SNF, which don't really work if you're designing a house, nor would we want to do all of those things. We wouldn't have been able to create the feel, create the facility that we did that way. So CDPH does have a fire life safety equivalency worksheet, and it's more than one page, but I'm giving you an example here. But it is a form downloadable from their website, and it allows you a path to create this facility, more or less, where you're looking at the risk generated by what you're doing in the facility, and you're creating a multiplier factor based on how many patients you have, whether they're ambulatory, their age, all those things. And then on the flip side, you're taking a look at the facility. Is it a type 5 non-rated? How wide are your corridors? Do you have direct exits out of your rooms? Are there sprinklers? Is there a fire alarm system? All of those components come together and give you a life safety score that basically has to be greater than the number of your risk score. It's a pretty sort of simple math when it comes down to it. And this is the path forward to essentially building a house that can meet CDPH requirements without being a skilled nursing facility and being designed as such. So you have to sort of pick and choose what things you're going to do to meet those requirements. Our issues, one was the emergency generator, which we had, but it was a manual, not automatic, because if it were automatic, it was going to be too loud and it wouldn't have been allowed by the county. So in order to fix that, a lighting inverter was accepted. We were a new structure here. We had sprinklers, but fire alarms, I had to upgrade that system to make it work. And we needed to go back and get some building permit things for items that weren't really looked at as a building permit in order to get our paperwork right for CDPH. So all those things together really got us there, but a little bit was a scramble at the end once they did their inspection. That said, we're moving forward now with a new house. It'll be our fourth house, and we're using the model Bonita View to really design it in the same model, with just a few maybe notes moving forward in time, that maybe a little bit more technology that we had in the Bonita View house. As healthcare, we've got a lot more systems and softwares and items that can help us be more efficient now. And I'm trying to think what the other main thing, sustainability.
Net zero, net green, net zero.
The other goal for the next house is really for it to be a net zero house, completely powered by the sun. Obviously with battery backup for nighttime, and to replace the need for a diesel generator. So if I can power a battery pack with the power grid, I hope I can power it with the sun. We may go away from gas in the kitchen, which is a little bit tricky to do, but anything we can do, I'd like to think net zero is where we need to be headed in healthcare in general. And if I can't do it in a hospice house, I'm going to never be able to do it in a hospital. So I feel like if I can't do it here, then we're not headed in the right direction. So that is our presentation. I don't see any questions or anything in the chat right now, but we have a few minutes. If anyone on the line does have any questions, we be able to read them and answer them. No questions currently. All right. Well, I hope it's been interesting to anyone who's been listening. We don't know.
Yeah. Thank you. Thanks, Matt. Always a great job and great partnership between Matt, the architect, and the project manager, and the VP, and our relationship for really understanding what we're trying to accomplish together is really one of the most fulfilling parts for me. So thanks, Matt.
Well, thank you, Susie, for joining us today. I hope we shed some light on a very interesting subset of the healthcare industry that doesn't get talked about much, and a lot of people doesn't even know exists. So.
Thanks, Matt.
Thank you.